Hello, my name is Sarah Stoneham. I'm a paediatric and adolescent oncologist based at University College Hospital, London, in the UK, and I'm going to talk today about germ cell tumours, particularly testis cancer. When in a consultation with a young person discussing testis cancer, we hope that this is not what they're thinking. But let's spend a little time talking through testis cancer and think around some of the things that might change that young person's mind if this is what they are indeed thinking. Some of the key points that we will be covering today is talking about this rare cancer, but how it impacts on young adults. We'll talk about the survival, how excellent that is, but what the cost of that cure is. We'll think around novel biomarkers and trial design and how that may truly impact on personalising treatment. Let's start by looking at incidence. We said that testis cancer is rare, and this is drawn out in data from NCRI. If you look at the two columns on the right-hand side of the slide, the far right column is predominated by carcinomas represented in red. There is a small gold line above the red line which represents testis cancer and other germ cell tumours. And as you can see, it represents less than 1% of all diagnoses made between the age of 0 and 79 years in the UK. If we look at the column on the left-hand side, you'll see that gold bar is proportionately much larger. And this represents the fact that in teenagers and young adults, germ cell tumours represent the third most common diagnosis seen and treated. So although testis cancer is rare, it still constitutes the most common diagnosis of cancer in men under the age of 40. 1 to 2% of germ cell tumours are bilateral, but the majority of tumours in the testis are germ cell tumours. Other diagnoses include sex-walled stromal tumours, for example. Some of the tumours that we see and diagnose are extragonadal, other sites being intracranial or mediastinal, but are not common. The peak incidence, as you'll see from the age histograms on the right-hand side of the slide, testicular cancer peaks in the 30s to 40s, non-seminoma being more predominant within the third decade of life, and seminoma being more predominant in the fourth decade of life. We'll see from the next slide that there is increasing incidence and global variation. GloboCan in 2008 published age standardised incidence rates across the world. As you'll see, for testis cancer, the ASIR is highest in Western Europe at 7.8%, with significant geographical variation and very little incidence being seen in Africa or Asia. This slide shows some of the histological variation seen in germ cell tumours. On the very far left-hand side, you'll see normal testis. Adjacent to that, close to the middle, is seminoma. On the right-hand side, though, is non-seminomatous germ cell tumour with evidence of invasion from choriocarcinoma. As with many cancers, staging is important to help us prognosticate. The TNM classification is used for staging, and prognosis is then refined using the International Germ Cell Cancer Collaborative Group's risk stratification, which has been developed and recently updated to help us understand prognosis. It offers progression-free survival predictions based on stage and tumour markers and histological subtype. Staging and prognosis will help us understand the burden of therapy required for best outcome. Most patients will require a radical orchidectomy, Some will require testis-sparing surgery, for example in the case of bilateral disease. But chemotherapy has not really changed over the last 50 years. It remains the gold standard of chemotherapy treatments, and most patients that require chemotherapy for cure will receive this. The role of radiotherapy and its judicious use can be employed in seminoma, and there is a consideration of removal of metastatic disease, either in a retroperitoneal lymph node dissection or sites of other disease beyond that. The European Society for Medical Oncology has treatment recommendations for both seminoma and for non-seminomatous germ cell tumours. And you'll see from this flow diagram and the one on the subsequent slide that there is a range of treatment options available. For example, for stage 1, you have some options around surveillance or treatment. And similarly, for stage 2A, there's choices between chemotherapy or radiotherapy or clinical trial options. If we then move to the following slide, this slide shows treatment options for non-seminomatous germ cell tumours, again with a range of options depending on risk stratification for stage 1, and similarly for stage 2 and above, depending on whether you fall into the category of good, intermediate or poor prognosis disease. We described at the beginning of the talk how curable most testicular germ cell tumour cancers can be, but there is a burden of late effects associated with cure, either from chemo or radiotherapy or from surgery as well. And this ranges from second malignancies to cardiovascular disease with metabolic syndrome, neuropathies, ototoxicities, nephrotoxicities, and others listed here as well. As we described earlier on, many of these patients who are diagnosed with testis cancer are under the age of 40. And Lois Travis and her group showed that the earlier your diagnosis and treatment was, the more likely you were over your lifetime to develop a second malignancy. And this is important for patients who are diagnosed with a curable cancer. One thing that may help us think around developing kinder treatments and allowing for cure at least possible treatment cost is the development of microRNAs. MicroRNAs are small non-coding pieces of RNA that are made by malignant germ cell tumours. What we have learned so far is that they're highly sensitive and highly specific, but they need to be validated in clinical trials to show that they're useful for all patients with germ cell tumours in all situations. But they might help us understand how much treatment is required, and they might help reduce the burden of disease surveillance options. So if we were going back to our young man at the beginning and asking him what would good clinical trial design look like for testis cancer, here are some of the things that I think he might ask us for. I think he'd ask us for patient-reported outcomes to be included in trial design so that we understand truly what it feels like to be a patient going through this treatment. That for those patients where the treatment outcomes are good, that we would de-escalate treatment and offer something kinder and gentler. For those patients, better identification of those that aren't going to do well earlier on and an ability to intensify those treatment options. And for those that are not cured by surgery alone, kinder treatments that have less toxic long-term side effects. So if our patient is now feeling heard, it's because we're offering a more personalised, risk-adapted treatment choice with fewer side effects. For the second part of this presentation, I interviewed a patient who had been offered a choice between chemotherapy and surveillance for stage 1 non-seminomatous germ cell tumour. He reflected with me how he made those choices and what the things were that were important to him at the time. I'm now going to play the video for you.
So, Jared, thank you so much for joining me today to help talk through how you made decisions around the choice between surveillance and a cycle of BEP chemotherapy when you were faced with the knowledge that you were diagnosed with testis cancer and there were some options around next steps. So what I'd be really grateful for is an understanding of when you first had that conversation, what was going through your mind?
Well, I think I quite kind of immediately, when I was sort of confronted with the dilemma, I sort of just looked to like my dad and my brothers, and I think everyone's immediate reaction always goes to like one extreme. So like the people who were in the room when the dilemma was explained to us sort of immediately went to don't get it. But then when I came home and explained it to like my brother, and I called my sister and explained it to them, they were like, no, you should do it. So I think it was tricky for me to make a decision because I suppose, given sort of the weight of the situation, under the label cancer, it gives it a lot of weight, and so it feels like every decision you make is really, really high stakes. And you know, I suppose in my situation, and I guess with testicular cancer in general, it's generally not life threatening. So I think I found it hard to originally sort of understand where I was, because there were so many conflicting understandings of what was going on around me. And I think after a while, I sort of took what everyone was saying, and I was just like, realistically, what is it here that is going to affect me the most? And I just thought I'll just take the chance of not, and I'm sure it would be fine. And if it isn't fine, then that's what happens, and that's just what happened. I didn't see a point in sort of interfering with whatever the course of action was.
So to you, after all of your thoughts, considerations, and discussions, it didn't feel like you were taking a risk. It felt like you were making a decision rather than taking a risk.
Yeah. I didn't really feel like I was taking a risk, and I don't feel like I live with a risk today. I think I would have been taking more of a risk if I did the chemotherapy, because I like, because for me it was kind of like this. It was like, either I have a 40% chance of it coming back and I don't do chemo, or I have a 2% chance of it coming back and an 100% chance of getting really ill for 3 months. So I was like, I'll take the other odds. I don't really want to be ill. I feel like if, because I'm quite active and I like doing a lot of active things and just being able to be very independent. I think that's a big part of how I like to sort of define who I am. And I felt like if I put myself in a position where I was sort of unable to properly take care of myself, and it was my decision that I did that, then I just wouldn't agree with that. I didn't feel like that was the kind of thing that I would do. But if it was that that's just how things worked out, I suppose, then that's just how it happens, and you sort of just have to take that as it comes. So I suppose really it's just a mindset about outcomes. But I felt like I was taking the safer option. Sort of, it felt like the most self-preserving option.
And do you think there was any more that us as a healthcare team could have done to offer you more support around that decision making, more information? What would you have liked, sort of knowing what you know now and with some time to reflect, anything that we should have and could learn from?
I think the whole situation was handled really, really well. Like by you and your team. I think it was handled amazingly. I think every question was answered directly. And like it's very common when, I mean, obviously not just in healthcare, but with anything, and you just ask a question and you never get direct answers. But I think in a situation like that, it's really important to have direct and short answers, and that was given really well. And I think there was a good amount of for and against. That wasn't like we think you should do this. It was really laid out as these are the pros and the cons for each one. This is really up to you to decide, because it's not because we wouldn't usually do this, but it's available. So if you want to do it, you can do it. And I think for me, you said earlier that some people find the choice like mortifying, and some people find it quite empowering. I think I did find it quite empowering, because I suppose it gave me a level of control over the situation. So I think like even if I said chemo and they were like, no, I'm joking, we don't do that. Even the fact that I had the choice, I think was quite a nice level of control.
Yeah. Okay. And then choosing surveillance, and then being part of a clinical trial. I'm conscious that that was a large conversation with lots of different things to think about. What were your thoughts around enrolling in a clinical trial for surveillance?
I don't know. I didn't really think about it that much. I kind of just thought, if I'm in this situation anyway, I might as well benefit from it somehow, or have other people benefit from it somehow, because I didn't really suffer that much from it. Like that day I had surgery was actually quite a good day. I've had way worse days, so I didn't actually like suffer that much. I mean, I think I suppose from the like immediate kind of sort of emotional shock after they were like, yeah, nah, and I was just sort of a bit shocked after. But after that, I think I kind of just got used to it, the idea of it. And yeah, I'm really thankful for the experience, I think, because it really sort of opened up my view of the world. And so yeah, I it wasn't that big of a choice for me. I think same with doing this as well. I just thought there's no harm in doing it, and it can only do good. And if I was in this situation anyway, and I'm one of the few people who's in the position to talk about it, I might as well.
Okay, thank you. Is there anything that you would have advise any of your peers, so young men and teenagers thinking around these decisions? Do you have any advice for them?
I don't know. I suppose don't just do what your parents say, because at the end of the day, it's you, and like the chemicals in chemo are really powerful. So it's not just going to affect you for that time. Most likely it's going to probably have after effects. So really actually take a while to properly internalize and understand the question and the dilemma, and do what you feel, I think. But at the same time, it's important not to act out of panic, or in a stress environment. It's really important to allow yourself to calm down and sort of, if you can, pull yourself away from the stress of the situation. I think, you know, a lot of my family members were quite distressed by the idea, understandably, but I felt that it was really unhelpful for me to be around that, because I wasn't actually that worried about it after a couple of days. But obviously, like, my mum and my sister were like crying about it a lot, and they were really distressed about it, which is completely understandable. But I felt that in order for me to make a proper decision about how to go forward, I needed a calm environment away from the situation, to feel like I was sure. So yeah, that's the advice I give.
Okay, that's really helpful. Thank you. And I guess my final question is, any regrets about your decision? Would you make the same decision again, or would you do anything differently?
Yeah, I'd make the same decision again. I'm pretty happy with my decision. I mean, I feel healthy now. Yeah, I don't have any regrets.
Thank you.